So good day everyone. Our first topic for today is going to be your renal function test. So what is clearance? Well, renal clearance relates the rate of urinary excretion of material to the plasma concentration of that same material. It is defined as the volume of plasma that would theoretically have to be cleared of the substance in order to account the amount of the substance excreted in the urine during a given period. So you can see on the formula given below, you have your CL is equal to U times V over P. What does this mean? Well, clearance, that's your CL, is equal to the urine concentration of your substance multiplied by the rate of urine flow divided by the plasma concentration of the same substance. So solving for that formula will give you the clearance rate of that substance. So why do we need to measure your glomerular filtration rate or your GFR? Well, this is because GFR is generally considered to be the best overall indicator of the level of kidney function. You can either measure your GFR through endogenous or exogenous methods. For exogenous methods, you'd have your inulin clearance. This was historically regarded as the gold standard for measuring GFR. This requires an intravenous infusion and timed urine collection. However, the major downsides to this procedure is that it is not only expensive, but time consuming as well. As such, it's not performed clinically. In the lab, we're going to be mainly using endogenous substances such as your creatinine, urea. However, cystatin C, beta trace protein, your beta 2 microglobulin, and your tryptophan glycoconjugate could also be measured in certain cases. Your creatinine is produced by your muscles from creatine and the creatine phosphate pool. It is proportionate to the muscle mass, but additional sources may be obtained by the ingestion of meat. So the rate of in vitro conversion of creatine to creatinine in meat is dependent on the temperature and acidity, where high temperature and low pH increase the conversion. Your creatinine is the most widely used marker for GFR. It is an endogenous substance with a fairly constant rate of production, and it is not bound to plasma proteins. When renal function is normal and stable, creatinine excretion is almost equal to its production, which depends primarily on muscle mass. Muscle mass varies with sex, age, and body weight. The creatinine production rate is estimated as age, so you can see on the formulas given below. If the patient is a male, it's 28 minus 0.2 times their age, whereas if the patient is a female, it's 23.8 minus 0.17 multiplied by their age. Even though your creatinine is your most widely used marker, it still has its drawbacks. The first is that it has substantial individual variation and depends mainly on the muscle mass of your patient. Additionally, creatinine is also derived from dietary meat, and the quantity of meat ingestion can substantially influence the total daily production. Since creatinine is commonly measured using the alkaline picrate method, it can be subject to many interferences. And your last is that creatinine is partially secreted by the proximal tubules via the organic cation transport pathway, and this tubular secretion may be blocked by various drugs. Some specimens that you can use for creatinine measurement can be serum, heparinized plasma, or diluted urine. Take note, however, that when you're using plasma, ammonium heparinized plasma should not be used for methods that measure ammonium concentration to quantify creatinine. Creatinine is stable in serum or plasma for up to 1 week if the specimen has been refrigerated. It is important to separate the cells promptly to prevent hemolysis and to minimize ammonia production. Hemolysis can cause falsely elevated creatinine values. For creatinine measurement, this is based off on the Jaffe reaction, where creatinine reacts with alkaline picrate to form an orange-red solution that is measured in the spectrophotometer. So the following are methods used in automated analyzers. First, you have your kinetic alkaline picrate method. The second is your enzymatic creatinine method, which is more specific and more sensitive. And the third is your isotope dilution mass spectrometry, which is the most definitive method, making it the basis of calibration of modern creatinine assays. Without removing non-creatinine chromogens, the upper limit of normal measured is around 1.6 to 1.9 mg per dl for adults. The upper normal, if after you remove those chromogens, is around 1.2 to 1.4 mg per dl. The values for women are around 0.1 to 0.2 mg per dl lower. When serum creatinine is very high, non-creatinine chromogens contribute proportionally less to the total reaction. With normal renal function, non-creatinine chromogens make up 14% of the total, but in advanced renal dysfunction, it contributes up to only about 5%. Next, let's move on to some formulas to estimate creatinine clearance as an estimate of your GFR. Up first is your Cockcroft and Gault formula. It is calculated by, first, having 140 subtracted by the patient's age multiplied by their ideal body weight. Divide this number then by 72 multiplied by their serum creatinine concentration. If the patient is female, multiply that value by 0.85. So how do you solve for the patient's ideal body weight? Well, basing on the formula below, if the patient is a male, you get 50 kilograms, and then you add 2.3 kilograms for each inch over 5 feet. If the patient is a female, instead of 50, you'd need 45.5 and then add 2.3 for each inch over 5 feet. So up next is your MDRD, or your modification of diet in renal disease study formula. Take note of the different variables you need to solve for it. For example, your creatinine, the patient's age, BUN, and then the albumin, and additional factors as well if the patient is black and female. For the simplified MDRD, again, take note of the necessary lab tests. For example, your creatinine, and then the patient's age, a multiplier if they are black and if they are a woman. So up next is your urea. Urea is the main waste product of nitrogen-containing chemicals in the body. By custom, the concentration of urea is expressed only by the nitrogen content. Its value as a measure of GFR is not very good for several reasons. The first being that urea concentration in the serum depends not only on the renal function, but the rate of urea production, which is largely on the protein intake. There are three main methods for the measurement of urea. First is your isotope dilution mass spectrometry, your colorimetric method, and then your enzymatic method. Your IDMS is considered to be the gold standard and the reference method for the measurement of your urea. However, it comes with a downside of having high costs. Your colorimetric method, on the other hand, is where when urea reacts directly with diacetyl monoxide under strong acidic conditions, giving you a yellow condensation product. The reaction is intensified by the presence of ferric ions and thiosemicarbazide. The intense red color formed is then measured at 540 nanometers. For the enzymatic methods, the measurement of ammonia is most often used. This begins with the hydrolysis of urea by urease, producing ammonia and CO2. The products are then measured to calculate the concentration of urea. Ammonia converts glutamate and ATP to glutamine and ADP. The ADP produced is consumed in reactions catalyzed sequentially by pyruvate kinase and pyridate oxidase to generate hydrogen peroxide. The ammonia produced from the urea hydrolysis reacts with alpha-ketoglutarate and NADH to produce glutamic acid and NAD by glutamate dehydrogenase. The amount of NADH consumed is measured photometrically to determine the urea concentration. So here you have a summary of the chemical reactions that have occurred. So I mentioned earlier, urea is acted upon by urease, forming your ammonia. Ammonia and your oxoglutarate, along with your NADH, are acted upon by your glutamate dehydrogenase, forming glutamate, NAD, and H2O. So what we're measuring here is the amount of NADH consumed. Let's move on to azotemia. But first, let's differentiate azotemia from your uremia. So uremia is a condition of abnormally high urea nitrogen in the blood. In contrast, your azotemia, most commonly seen in kidney insufficiency, is a significant increase in the plasma concentrations of both urea and your creatinine. Azotemia may occur in your pre-renal, renal, or post-renal forms. In pre-renal azotemia, this is mainly due to poor perfusion of the kidneys and therefore diminished glomerular filtration. This is most commonly caused by dehydration, shock, and severe burns. For your renal azotemia, this is caused by a diminished glomerular filtration as a consequence of acute or chronic renal disease, most commonly caused by your acute or chronic glomerulonephritis, your PKD, as well as your nephrosclerosis. And for your post-renal azotemia, This is due to obstruction in which urea is reabsorbed into the circulation. Some of the more common causes are stones, an enlarged prostate, or some tumors. So for your BUN to creatinine ratio, the normal ratio for a person on a normal diet is between 12 to 20 milligrams per DL. If the ratio is significantly low, this may indicate acute tubular necrosis, low protein intake, starvation, or severe liver disease. High ratios with normal creatinine values indicate tissue breakdown, pre-renal azotemia, or high protein intake. High ratios with increased creatinine may indicate a post-renal obstruction or pre-renal azotemia associated with a renal disease. So on this slide, we have a figure showing the possible causes for variations in your BUN to creatinine ratio. For example, if your BUN creatinine ratio is low, one possible cause could be starvation or ATN. If your BUN to creatinine ratio is high but the creatinine is normal, it could be caused by pre-renal uremia or high protein intake. But if your BUN choreo ratio is high and the creatinine is increased, this may be caused by post-renal obstruction or pre-renal uremia with renal disease. So the other tests for renal function are your cystatin C, which has been identified as a marker superior to serum creatinine for GFR assessment. It is present in constant amounts in all body cells and is not influenced by muscle mass. GFR is inversely proportional to cystatin C concentration. Next, you have your beta-2 microglobulin, which is present in all nucleated cells and is needed for the production of your CD8 cells. In cases of multiple myeloma and lymphoma, your beta-2 microglobulin is increased, and plasma level increases in renal failure. Next is your beta trace protein. This is a low molecular weight glycoprotein with 168 amino acids. Your BTP belongs to the lipocalin protein family and functions as prostaglandin D synthase. Plasma levels is increased in patients with renal disease because of the reduction in filtration in the presence of constant production. And lastly, you have your tryptophan glycoconjugate. Your MPT is a substance normally produced in the body by glycoconjugation of your tryptophan and is filtered at the glomerulus freely and not reabsorbed. Serum levels increases progressively with declining renal function, and serum MPT concentration is not affected by muscle mass. And that wraps up your tests for renal function. The next topic for today is your electrolytes. So a brief definition onto what electrolytes are. Electrolytes are ions or minerals capable of carrying an electric charge, classified as either anions or cations depending on the type of charge that they carry and how each ion migrates in an electric field. Your cations have a positive charge and move toward the cathode, while your anions has a negative charge and move towards the anode. First up is your sodium. Sodium is the most abundant extracellular cation, and it determines the osmolality of your plasma. When collecting specimens for your sodium measurement, serum, plasma, and urine can be used. Take note that when using plasma, use lithium heparin, ammonium heparin, or oxalate heparin. 24-hour collection of your urine is the specimen of choice in urine sodium analysis. Whole blood and sweat may also be used as specimens. In the case of sodium, an ion-selective electrode is most commonly used in the laboratory to measure your sodium levels. You can see on the table on the left some possible causes for hyponatremia and hypernatremia. For your hypernatremia, this may be caused by excessive loss of water through overhead heater, fluid deprivation, or administration of hypertonic fluids containing sodium. In cases of hyponatremia, this may be due to inappropriate ADH secretion, renal tubular acidosis, as well as diuretic use. Normal values for sodium range between 135 to 145 mg per dl, with low critical values at less than or equal to 125 and high critical values at greater than or equal to 160. Next is your potassium, which is considered to be the major intracellular cation. Potassium is responsible for your neuromuscular excitability, the contraction of the heart, and your hydrogen concentration. The specimen used for your potassium measurements are your serum, plasma, and urine. Heparin is the anticoagulant of choice, and take note to avoid hemolysis. Again, ion selective electrodes are most commonly used in the laboratory, especially your valinomycin membrane. Some possible causes for your hyperkalemia involve fluid deprivation or dehydration causing tissue leakage, intravascular hemorrhage causing release from your red cells, and trauma or tissue damage. For hypokalemia, this may be due to inappropriate ADH secretion, diuretics, especially your furosemide, alkalosis, and pyloric stenosis. Normal values are between 3.5 to 5, with low critical values being less than or equal to 3, and high critical values at being greater than or equal to 6. Next is your chloride, which is a major extracellular anion. Chloride is involved in maintaining osmolality, blood volume, and electric neutrality. The specimen used in chloride determination can either be serum or plasma, with again your lithium heparin as the anticoagulant of choice. Sweat may also be used. Similar to the previous mentioned electrolytes, your iron selective electrode is the most commonly used. However, it's nice to take note of your Kotlov chloridometer, which uses silver ions to combine with chloride in order to quantitate chloride concentration. So again, you have a table on the left for the possible causes of your hyper and hypochloremia, as well as the normal value for chloride, which is around 98 to 106, with low critical values of less than or equal to 80, and high critical values of greater than or equal to 120. Up next is bicarbonate, which is the second most abundant extracellular anion. It is the major component of the buffering system in the blood. The specimen used can either be serum or lithium heparin plasma. Specimens should be kept in an anaerobic condition for highest accuracy, and they need to be capped until measured, else bicarbonate levels can decrease by up to 6 millimoles per liter per hour. Again, an ion selective electrode and enzymatic method can also be used. So in summary, you have your intracellular cations being mainly your potassium, followed by your magnesium. Your intracellular anion is your phosphate. Your extracellular cations are your sodium and calcium, and your extracellular anions are chloride and bicarbonate. Some of the key functions of your electrolytes are for volume and osmotic regulation, you'd have sodium, potassium, and chloride, myocardial rhythm and contractility, potassium, magnesium, and calcium, cofactors in enzyme activation, your calcium, magnesium, zinc, and chloride, regulation of your ATPase ion pumps is your magnesium. For your acid-base balance, you'd have calcium and magnesium. For your production and use of ATP from glucose, it's magnesium and phosphate. So in summary, your major intracellular cation is your potassium and your magnesium. Your major intracellular anion is your phosphate. Extracellular cation is sodium, followed by your calcium, and your extracellular anion is your chloride and your bicarbonate. Additional key functions of your electrolytes are for volume and osmotic regulation, you'd have sodium, potassium, and chloride. Your regulation of your ATPase ion pumps is your magnesium. For your blood coagulation, it's your calcium and your magnesium. And for the production and use of ATP from glucose, it's your magnesium and phosphate. Your anion gap is the difference between unmeasured anions and unmeasured cations. Electrolytes routinely used to approximate the anion gap are your sodium, your potassium, chloride, and your bicarbonate as total CO2. The reference range is around 10 to 20 millimoles per liter. So in solving for the anion gap, you just need to subtract anions from your cations. For example, given the 4 electrolytes, you would need to add both sodium and potassium and then subtract the sum of chloride and bicarbonate. This would give you your anion gap. Some of the causes for an elevated anion gap could be uremia or renal failure, ketoacidosis, lactic acidosis, and hypernatremia. Low anion gap causes are, although rare, they could be due to hypoalbuminemia, in which case there would be a decrease in unmeasured anions, severe hypercalcemia, which causes an increase in unmeasured cations. And finally, you'd have your acid-base balance. Let's start off with some definition of terms. An acid is a substance that donates a proton, while a base is a substance that accepts a proton. pH is the negative log of your hydrogen concentrations, and the pH value of 7 means that it is neutral. If it's less than 7, it's acidic, and if it's greater than 7, you call it alkaline or basic. PCO2, or your partial pressure of CO2 in the blood, is measured in mmHg and is generally acidic, while your HCO3, or your concentration of bicarbonate in the blood, is measured in milliequivalents per liter and is alkaline. This slide shows the normal values for each test. You would do well to memorize these values as this is very important while calculating for compensated, partially compensated, or fully compensated acidosis or alkalosis. So how can we classify whether the disturbance is respiratory or metabolic in nature? In respiratory, this is generally where the initial disturbance involves your PCO2, while it's metabolic if it involves your bicarbonate. In respiratory, you can classify it as respiratory if the changes in PCO2 and hydrogen are directly proportional. This means if there's respiratory acidosis, the PCO2 is high. If there's respiratory alkalosis, the PCO2 is low. It is metabolic if the changes in your PCO2 and your H are inversely proportional. It's metabolic acidosis if it's low PCO2 and metabolic alkalosis if it's high PCO2. So the body can deal with acid-base disturbances in the following ways: either through chemical buffering, the regulation of your PCO2 by varying the ventilation of the body, or controlling plasma bicarbonate by changing renal hydrogen secretion. After we have determined the primary disorder, check for the presence and degree of compensation. For example, in your respiratory acidosis, the body will tend to compensate by elevating HCO3. In cases of your respiratory alkalosis, HCO3 will be decreased. In metabolic acidosis, PCO2 is decreased, and in metabolic alkalosis, PCO2 is increased. It is partially compensated when the pH is approaching normal, but it is fully compensated when the pH has returned to its normal range. Compensatory mechanism can include for your primary, another organ will compensate, while for secondary compensation, the organ itself will compensate. So on this slide, we have several examples of partially compensated disorders. For example, you have respiratory acidosis. So how can we tell that it's respiratory acidosis? Well, the primary disorder must involve your CO2. So is CO2 acidic or alkaline? It's acidic. So taking that into account, we expect that CO2 would be increased. So what does the body do to neutralize this effect? Well, the body will try to increase bicarbonate. So by increasing bicarbonate, which is alkaline, the body will attempt to neutralize the acidity. However, we can only classify this as partially compensated as the pH is still not normal. So as you can see on the column under pH, the pH is still decreased. Now take a look at the same row. We have respiratory acidosis, where CO2 is increased and the body compensates, so increase in your bicarbonate. But take note of how the pH is now normal. Because of this, we can tell, or we can say, that this is a fully compensated respiratory acidosis. In cases of metabolic acidosis, it's important to calculate the anion gap. So compare this to the formula I showed earlier. This one does not have potassium. Some equations tend to not have potassium while others have potassium, so just take note. Anyways, the causes of your metabolic gap acidosis are your mud piles or mud pilers, while for the non-gap metabolic acidosis, it's your hard ups. For your metabolic alkalosis, general laboratory findings include decreased hydrogen, increased bicarbonate, the PCO2 is normal or slightly elevated, and urine pH is greater than 7. For the etiologies, volume contracted due to vomiting, diuretic use or abuse, and the volume is not contracted if hypertension is present, consider hyperaldosterone states, otherwise consider magnesium depletion or renal failure. In cases of respiratory acidosis, the following are your laboratory findings. there would be an increase in your hydrogen, an increase in your PCO2. Bicarbonate can be normal or slightly increased. Renal compensation takes around 24 hours to take effect, which increases your bicarbonate. And the possible etiology for respiratory acidosis could be alveolar hypoventilation. For your respiratory alkalosis, possible laboratory findings include a decreased hydrogen concentration, decreased PCO2, with the bicarbonate normal or slightly decreased. Again, renal compensation takes around 24 hours to take effect, decreasing your bicarbonate. For the etiologies, alveolar hypotension is the most common cause in patients with serious illnesses. However, anxiety, fever, sepsis, and early asthma may also cause respiratory alkalosis. For the specimen collection, use arterial blood collected using a glass syringe with heparin. Take note that heparin is the anticoagulant of choice when performing your ABG. Always note to perform Allen's test to assess the integrity of the ulnar artery before your patient undergoes radial artery puncture or cannulation. Your Allen's test can be performed by having the patient clench their fist and covering both radial arteries on both hands. The initial pallor should be then replaced by rubor or redness. Process your specimen stat, keep it in anaerobic condition and chilled as well, because pH increases by 0.01 by every 20-minute delay. And that's my last topic for your clinical chemistry. Thank you so much for listening and have a good day.